Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
A quick reminder before we begin, you can always send us your questions for Dr. Mingle. You can leave them in a comment on YouTube, or you can email them directly to us at hello@minglehealth.com. In today's episode, Dr. Mingle will be taking a closer look at data for quality reporting. At Mingle Health, we often see confusion and experience a recurring set of questions about data. So we thought we'd get into those questions and try to clear some of that confusion. So my first question for you, Dr. Mingle, is what data do you need to calculate quality measures?
Great question, Kyle. Let's start with a simple definition of healthcare quality measurement. It doesn't matter whether measuring for the merit-based incentive payment system, that is MIPS, the APM performance pathway, that's the new APP, the healthcare effectiveness data and information set, that's commonly known as HEDIS, or any other healthcare measurement set. Every quality measure is asking a variation on a single fundamental question. Have our patients received the health care we intend them to receive? Now, that care can be defined in terms of an outcome, like the level of blood pressure control or hemoglobin A1C, or it can be determined in terms of an intervention, like ACE inhibitors in our patients with left ventricular systolic dysfunction, or annual influenza vaccination for those who are eligible, or say a potassium level for patients on diuretics. There are other kinds of quality measures, but the most common we experience involve the relationship between two numbers, the numerator and the denominator. The denominator defines and counts for any given outcome or intervention the eligible instances in our practices for the outcome or intervention. Now, when I say instance, it could be patients eligible for a certain intervention, like women over 50 who might need a mammogram, or visits eligible for an intervention, like healthcare visits during which the level of pain was assessed. Now, the numerator defines and counts relative to each instance in the denominator those eligible instances who achieved the designated level of control or received the desired intervention. That typical quality measure is expressed as a fraction, the numerator over the denominator, the count of those who have achieved the outcome or received the intervention over or divided by the count of those eligible for the outcome or intervention. The denominator, the account of eligible instances, is literally the bottommost number in the fraction and is also figuratively the foundation of the measure. We start with the denominator. The denominator comes first. We can't measure performance until we know which and how many patients or which and how many visits the measure applies to. Every measure has a set of measure specifications. Measure specifications should spell out, with no ambiguity, the eligibility or denominator specifications and the performance or numerator specifications. To the extent that there is ambiguity, it's not a good specification document.
Great. Thank you, Dr. Mingle. And that brings me to the second question that we see a lot. Does numerator and denominator data come from the same place?
Great question, Kyle. It can come from the same place, but more often and more reliably, it comes from different sources. If there is a single source, that single source is usually the electronic health record, or EHR. More often, we get most of the data for our denominators from the practice management system, and most of the data for numerators from the electronic health record or clinical record, whatever that is. But there is tremendous variation from practice to practice. And Mingle excels at working with practices where they are, utilizing their strengths and working around their weaknesses. Sometimes there is historical data in a separate archive. Think a previously used EHR that's now a read-only system. We might combine data from the legacy EHR archive with that from the new EHR. Sometimes a reporting database is actively maintained as a preferred data source. There are the variety of distinct registries that hold useful subsets of data. And we can utilize any of these where there's accessible data. The most common of these is a tumor registry. Finally, we can help practices streamline their data abstraction processes to get data manually from their paper records, help you manually convert your text-based, paper record-based data into an Excel spreadsheet that we can import and integrate with the rest of your data. Your quality reporting registry needs to know, that is your vendor who's helping you with quality reporting, needs to know the strength, weaknesses, and limitations of each of those data sources and others to create with you an efficient and effective quality reporting system.
Okay, so Dr. Mingle, you explained that usually you get numerator and denominator data for quality reporting from different sources. How do you get denominator data?
The common theme here that I introduced in the last question is that there is great variation in the market, and flexibility is the key to serving all comers. Some of our clients are able to generate flat files. That's a simple data extract from the practice management system that includes all of the data we need. This may be a draw from multiple tables to bring them all under one. We prefer big raw files with a minimum of filtering. Every time a data set is filtered or otherwise handled or subjected to manipulation, we see errors and data loss. It's best to limit only by beginning and end date, and we can do the heavy lifting of filtering on exactly the data we want when we have that set in hand. Many practice management systems contain some canned reports into which some simple parameters can be introduced, such as that desirable beginning and end date. If one of those canned reports contains all the data we need, those can be quick, easy, and useful. It doesn't matter if there are fields included in the report that we don't need. It's easy to filter on our end and to take what we need and discard the rest. By far, the most common source of practice management data is 837 files. These are files that your practice management system prepares and sends periodically to your claims clearinghouse that go on to insurers for payment. These usually persist as an archive file in your system and can be periodically sent to us as the foundation of your denominator calculations.
So when we're talking about denominator data and eligible instances, we often see data completeness come up. Where does data completeness fit into all of this?
For the performance years 2023 and 2024, Medicare requires for the merit-based incentive payment system and the clinical quality measures option of the APM performance pathway that you submit performance data on at least 70% of your eligible instances. Starting with the 2025 performance year, Medicare has queued that data completeness criteria to go up to 75%. Also, remember that measures have a minimum denominator count as well. It's called a case minimum. With a few exceptions, that case minimum for most quality measures is 20 eligible instances. If you have fewer than 20 eligible instances for the measure, you won't get credit for submitting it. The preliminary count of eligible instances we make from the claims analysis is a great first pass determination for both the requirements for data completeness and eligibility based on case minimum. If our preliminary count is below case minimum, clinical data that is used to complete that eligibility analysis will never increase the count. It can only decrease it. If you fail case minimum on the preliminary count based on claims, you cannot get credit for that measure. Now, data completeness is interesting. If the clinical data is coming from your electronic health record, your EHR, and there's only one instance of a single EHR in your practice, by Medicare's definition, your data is 100% complete. It becomes an issue if your data comes from multiple EHRs, or if your data comes from a derived source, such as a tumor registry. In the first case, all clinical data comes from a single EHR. Medicare allows us to assume that the data is complete. For most measures, when we find performance data, performance is met. When the data is not found, performance is not met. All eligible instances are covered by one or the other possibility. And some of you recognize that I'm bleeping over a couple of complications, which just make this a more complicated discussion, those being inverse measures. The other issue being exceptions, which can create that third category of performance met, accepted or excluded, and performance not met. When the data is from a derived source like a tumor registry, finding performance data indicates performance is met. But lacking performance data, the question arises, is performance not met, or was there a failure to create an entry in the separate registry? Medicare requires us to consider the lack of data to be a lack of reporting, a decrement to the reporting rate. The exception to that rule is when the secondary data set explicitly documents a lack of performance. So if we can show the logical argument that the lack of data is reliably shows lack of performance, or that you actually explicitly describe a patient lacking performance in that registry, then we can improve that reporting rate from that derived data source. In complex systems where different EHR instances and possibly even paper records exist, it can be impossible or perhaps just cost prohibitive to get data from every system. Medicare's data completeness criteria determines how hard we need to try. Once we access 70% of the cases, we don't need to go any deeper.
In your answer to that question, Dr. Mingle, you touched on lacking data, and that brings us to our next common question. If we are lacking data, how do we know when we meet data completeness criteria?
Now that, Kyle, is an important concept. It's not often discussed, but you need a reliable count of eligible instances to know when your performance measurement exceeds the data completeness requirement. You need 100% of your eligibility data to know when you have 70% of your performance data. That's one advantage to our approach to denominator first from the claims data, numerator second from the clinical data. Even if we have only a preliminary count of eligible instances from the claims data, it gives us a credible measurement of data completeness as we collect the clinical data. We can be done when we have data on 70% of the eligible candidates. It's a bonus that the claims data is easier across complex organizations than is the clinical data.
Great. And we'll end today's episode with a question that we're seeing more often now as we approach the end of the web interface and the beginning of the APM performance pathway, the APP. So, Dr. Mingle, for our Medicare Shared Savings Program, MSSP clients who are now subject to the APM performance pathway, many of them have multiple EHRs resident in their participating practices. How do you know that we can serve them? It seems like a data aggregation issue and data completeness criteria is a severe limitation.
We've been at this since the introduction of the group practice reporting option, that's GPRO, in the days of the Physician Quality Reporting System, PQRS. Many of our larger clients working under a single tax ID number, that is TIN, have multiple EHRs. They're the product of consolidation of practices in a community, each practice coming in with their adopted EHR. We have used this approach successfully in all that time. It works. For practices of all sizes and types, we have the scars and the success that proves it. It's a rare practice that we can't get claims from. With claims data from all practices in the tax ID number in a MIPS submission, or all practices in the MSSP ACO for an APP submission, we can deduplicate patients across the system. We can reliably sort and count patients as eligible candidates for each measure. We can know in which practices each patient is engaged and might have data. We can match the clinical data, where we can get it, to the patients we identified from claims. We can reliably calculate both a reporting rate, that is reflecting data completeness, and a performance rate. which is critical for your scoring or collecting your shared savings. It will happen more often in the APP for MSSPs, that is the APM performance pathway for Medicare shared savings programs, but methods are built, proven, and hardened over 10 years in the PQRS and MIPS programs.
And in closing, I want to remind our listeners that they can always send us their questions. The easiest way to send us a question might be via email. Send it to hello@minglehealth.com. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you tuning in. Thanks for sending your great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct me, supplement my answers, share your experience, ask your questions. We can be smarter together.